Prostatitis and urinary tract infections will be the focus of this presentation for our group. This first section will go over prostatitis. The prostate is a walnut-sized male reproductive organ located below the bladder and in front of the rectum. The prostate makes fluid that combines with sperm to make semen. The prostate surrounds the urethra, and inflammation of the prostate can choke off the urethra, causing urinary obstruction and retention, thus increasing the risk for infection. There are 4 categories of prostatitis. These include acute bacterial, chronic bacterial, non-bacterial, and asymptomatic inflammatory. Acute bacterial prostatitis is caused by bacteria, most commonly E. coli. Acute bacterial prostatitis commonly co-occurs with urinary tract infections. Non-bacterial prostatitis, the cause of this is not known, and chronic prostatitis, the cause is by recurrent E. coli infections. These are the symptoms of prostatitis. These are grouped in the table below by urinary, pain, and sexual health. Urinary symptoms include a weaker urinary stream, urinary hesitancy, incomplete bladder emptying, frequency, urgency. Pain includes tender, swollen prostate, pain between the scrotum and rectum, painful urination, lower back and abdominal pain. Sexual health includes malaise and fatigue, anorexia, premature ejaculation, muscle aches, and blood or pus in the urine. Diagnosis for this can be done through a urinalysis, a CBC, a post-prostatic massage, and CT scans. Drug selection is based upon the bacteria associated with the prostatitis, the cost, and drug resistance. First choice of treatment for this is fluoroquinolones. Some adverse reactions to this are photosensitivity, skin irritation, dizziness, hypoglycemia, anaphylaxis, and a black box warning of spontaneous tendon rupture, and any tendon pain should be reported to their provider immediately. This next slide goes over treatment options, and these treatment options vary depending on whether it is acute or chronic, and complicated versus uncomplicated. The treatment varies by route. For an uncomplicated acute bacterial prostatitis, PO antibiotics such as Cipro can be given. For complicated acute bacterial prostatitis, IV antibiotics can be given. Those diagnosed with chronic prostatitis are given a longer treatment of antibiotics from 1 to 3 months, and then there's some also alternative drugs to be included if for whatever reason the patient cannot take the ciprofloxacin or other types of medications. Monitoring for this includes making sure there's a therapeutic response to the antibiotics prescribed. It's also important to assess renal and hepatic function and to monitor INR for patients who are taking Coumadin or warfarin. Also monitor for seizures or any central nervous system irritability if patients have a history of epilepsy or alcohol abuse. Renal dosing should also be completed if a creatinine clearance is under 50. Patient education includes taking the medication 1 hour before or 2 hours after other medications with a full glass of water. Absorption is impaired by dairy products, so that should be separated by at least 2 hours. And you should avoid within 2 to 6 hours of taking antacids, caraphate, iron, zinc. If these patients are severely ill or obese, they may require higher doses. There are other antibiotic classes that may be preferable depending on the patient's history, such as diabetes, a prolonged QTC, or epilepsy. And again, to reiterate, patients should report any tendon pain to their provider. This next section will go over urinary tract infections. Urinary tract infection refers to an infection present anywhere along the urinary tract, including the urethra, bladder, and kidneys. Approximately 6 million Americans suffer from UTIs each year, accounting for over 10 million office or emergency department visits annually. Next, I will go over the pathophysiology of UTIs. The most common pathogen is E. coli. Other pathogens that can cause UTIs are listed below. They can be caused by several factors. This includes irritation of mucosal tissues, indwelling catheters, congenital abnormalities, urinary retention, pregnancy, and more. Most infections are ascending, which means they start in their urethra and travel upward into the bladder and into the kidneys if left untreated. Females account for most cases, as the urinary tract is much smaller than that of men. Diagnosis of a UTI is based on symptoms and laboratory findings. This can be done by a urinalysis, culture, and sensitivity if indicated. The urine culture is not a requirement to start therapy, but may be indicated in those with recurrent UTIs or not responding to initial treatment after a few days. The next part is about rational drug selection. This is determined by adverse reactions, local patterns of resistance, patient variables, etc. First line of treatment for UTI is typically Bactrim. Alternative treatments or second-line options are ciprofloxacin. Also, the culture and sensitivity can help determine which antibiotic should be given for the patient. Here are the drug dosages for Bactrim for an uncomplicated UTI. Here we have listed the dosages for adult and geriatric as well as children who are greater than 2 years old. This next table goes over drug dosage and different medications that can be prescribed for UTIs. The drug can vary depending on patient variables, allergies, the type of bacteria that is found in the culture during the urinalysis. All of these are factors to contribute to what drug is chosen. The different dosage and considerations are listed for each drug, as you can see listed here. The adverse drug effects for Bactrim, the most common are nausea, vomiting, anorexia, rash, photosensitivity. Rare symptoms or adverse reactions are Stevens-Johnson syndrome, hepatitis, drug-to-drug interactions. Warfarin is one of them. This can lead to an increased INR. And warfarin will typically require reduction of dosage by 25 to 40% during therapy. For patient education, if the UTI is recurrent, then a urine culture should be done and labs should be drawn. If the child is less than 5 years old, they should be evaluated by a pediatric urologist. Urine culture should be done after therapy in pregnant patients, children, and those without symptom resolution. If symptoms don't improve within 48 hours, then the provider should reassess. Renal function should also be monitored, and medication should be taken after meals to help lessen any GI irritation. An important note is that patients should complete the full dose of antibiotics even if they are feeling better after just a few doses, because stopping antibiotics too early can cause antibiotic resistance. Urinary analgesics can be purchased over the counter and can also be given as prescription drugs to help with bladder discomfort and urgency that results from UTIs. There are some different ones. One of them is known as azo dye, and this can have direct analgesic effects on the urinary tract. There are different dosages and depends on the age range. This shouldn't be taken or used for more than 2 days if taken together with antibiotics, and is not recommended for children younger than the age of 6. Here is the list of references that were used throughout this presentation. Thank you for watching.